So topics covered in this chapter is the emergency medical services system as a whole, components of the EMS system, research, and some special issues we might run into. So EMS as a whole began really with military applications. The first documented EMS system was in the 1790s with the French in the Napoleonic Wars. And really, all they were doing were going on the battlefield, finding wounded, and just taking them off so that they weren't in the battlefield anymore. Fast forward to the Civil War era, you had actual doctors that these people could be brought to. So there'd be doctors off of the battlefield, and the soldiers would be brought to the doctors from the battlefield. Then you fast forward to World War I. You have the introduction of volunteer ambulance corps. And so these are people who are actually dedicated to do these jobs. You weren't at the mercy of just a random person helping you out when they had a chance. You had people whose job was to move you. And then you get into World War II era, and then in Korea and Vietnam, you have people who are called medics who will actually provide some care at your side and be able to stabilize the patients a little bit, then transport them. In Korea and Vietnam specifically, you had the invention of using helicopters for patient transport. You also had MASH units. I don't know if you've ever seen the show MASH. It was based around this concept where there were field hospitals set up, and the patients would be brought to them by helicopter and or ground transport so that they could have faster care rendered. You'll see throughout the class that a lot of what we get from EMS comes from military applications, especially trauma-related things, and that's mainly because in military you have a high level of trauma in a short period of time, so it makes it so you can effectively study things quickly. It was about 10 years ago, maybe 20 years ago, that tourniquets were really frowned upon, and they were like the last line of defense for trying to stop a bleed, because they thought that if you put a tourniquet on, then the tissue in your extremity would start dying relatively quickly, and so you would lose that extremity if you put a tourniquet on. And they found during the Desert Storm and the Iraqi wars that tourniquets were actually much more effective at controlling bleeding, and they were relatively safe to use for hours and hours and hours on end until they could have vascular surgery to repair the bleed. And they were finding that it wasn't damaging the extremity all too much. So now tourniquets went from one of our last line things to it's one of our first line treatments of a major bleed. So that's just one example of how military application does apply to EMS even today. So going a little bit further into history, you have non-military ambulances began popping up in the early 1900s in the United States. Typically, these were hearses. They were operated by private hospitals, fire departments, or a lot of times funeral homes. And a lot of the hospitals would operate an ambulance just for transport to their hospital. So if Krause Hospital owned a ambulance, that ambulance would only go and bring people to Krause. Funeral homes would operate the ambulances mainly because, again, they were usually hearses, and funeral homes had those hearses. Some issues with the earlier ambulances of the day, they had zero requirements for equipment, crew training, or what you even find on an ambulance or what the ambulance is. It was just you might get this thing in one location, you might get something else in a different location. If you're lucky, just anyone will come and help you. In the bigger cities, especially with the fire department run ambulances, they were starting to try to find a nurse or a doctor that lived in the community to pick them up on the way to the call so that there could be some aid rendered. But it wasn't always a thing that could happen, and there was no standard of training among those nurses or doctors for emergency medicine. So a lot of these nurses and doctors didn't really know how to act in an emergency setting. So fast forwarding to EMS today. In 1966, the Department of Transportation was charged with developing EMS standards. That became, or that came out of what was called the White Paper. The White Paper was a study published by the National Academies of Science, and it was, I believe it was entitled Accidental Death and Disability, the Neglected Disease of a Modern Society. And really, what that was highlighting was how a lot of people who got into traffic accidents back then did not get care immediately, and they were either dying or having severe disability because they could not get quick care rendered to them. Imagine if you're up in the middle of Oswego County and you get in a really bad car accident, and the people who come get you have no medical training. Before you get to, from the time that you get an accident to the time that you get to Upstate, which is our trauma center, that's going to be an hour, maybe an hour and a half, depending on where you are, before you actually see first medical care if the ambulance can't give you medical care. So that's the problem that they were highlighting, is that we really needed to have a way to give medical care very quickly in the field. So because of that, the Department of Transportation was the agency that took over developing EMS standards. It went hand in hand because they're highlighting car accidents, so the Department of Transportation said, okay, this is our issue, since it has to do with cars. Moving on, in 1970, the National Registry of EMTs was founded. I'll discuss that a little bit later in this chapter. And then in 1973, the National Emergency Medical Service Systems Act was passed by Congress. And we're going to go into greater depth into that in just a minute. This was a quick video that was shown in class, about 2 minutes long, just kind of highlighting everything we just talked about. So in that law passed by Congress, it had several different standards that were laid out and kind of gave us the groundwork that we could build on that created EMS as we know it today. The NHTSA is the National Highway Traffic and Safety Administration. They are the ones that set out this standard. They are a part of the Department of Transportation, so they are the ones who laid out this groundwork. So it had multiple different points. First one was having regulation and policy. So saying that we need laws, policies, regulations in place, and they passed that power on to the states. So New York State is the one who will certify you to be an EMT, and they're the ones that establish the laws that govern what we do, as well as the policies. And so if you go to Pennsylvania, you'll have slightly different laws and policies, and you have to be certified by Pennsylvania. Your New York certification won't be able to translate between the two states because you have a few different laws. So Pennsylvania needs to make sure that you know their laws and policies and regulations. Another point that they put out was resource management. That's a centralized coordination of emergency treatment and transport resources, essentially spreading things out, making sure that we don't have a odd number of ambulances in this one little area that doesn't get a lot of calls, and then a big city has no ambulances. So having actual management of these resources that we're laying out was part of the standards that they said we needed. Another point was human resources and training. That's what you guys are doing right now. It's making sure that EMS personnel have minimum standards that they have to meet for their training. So that's, like I said, what we're doing right now in class is New York State said we need to teach these specific things, and the students need to meet these specific testing standards in order to become an EMT and be on the ambulance. So that was human resources and training. Also transportation, providing a safe and reliable transportation. So making standards for the quality that the ambulances themselves have to be in mechanically was part of this. Facilities, says transport to the closest appropriate facility. And that's very true. If you have a patient who has abdominal pain and you pick them up in Brewerton, you aren't going to let them go to Buffalo just because they like Buffalo's hospitals better. We will transport them to the facility that's closest and best able to handle their care. So in that case, that would be one of the Syracuse area hospitals would be closest to Brewerton. So we would say we cannot transport to Buffalo because that's just what you like. We have to bring you to the closest appropriate facility. And saying closest appropriate, is another huge part that we're going to be touching on. Appropriate means that they can handle the specific type of patient that you have. For example, in this region area, it's a pretty broad region, it's like 5 or 6 counties. Upstate Hospital is the only hospital designated as a trauma center. So if you have a patient with massive trauma injuries, that is the only appropriate facility in the area that can treat them. So even if you are 10 blocks away from Oswego Health, you should drive them the hour to Upstate because Oswego Health can't handle the massive trauma patients, but Upstate can. So that is the closest appropriate facility for them. Another point that they put out was communications. That's where we have the birth of 911, Universal System Access Number. Before then, really dependent on where you were, what number you called. It was usually a normal 7-digit phone number that you would have to call. You'd usually have a different one for police, one for fire, one for ambulance services. So it was very confusing. And if you were in an area that you did not know the numbers, you kind of were out of luck in your ability to call for someone. So establishing a universal number to call was huge in being able to request assistance if you're traveling out on the roads. Also, they standardized dispatch to ambulance, ambulance to ambulance, and ambulance to hospital communications. So having a way that we can actually contact the hospital or contact another ambulance or contact dispatch, which was the radio system that we currently use today. But making sure that we actually have those communications so we can talk to who we need to talk to at the appropriate times. That was a very big part of what they wanted laid out. Another part was public information and education. So being able to educate the public about the roles of EMS and access to EMS services. I'm sure everyone's heard the word ambulance driver before. Ambulance driver came from the time of before this was all established, where the people on the ambulance literally were ambulance drivers. They were not providing any sort of care. So they would just come pick you up and drive you to the ambulance. So having the public information back then of, hey, we are actual providers now who can take care of medical emergencies. So if you have something going on, it's better to call us so we can treat you first rather than just risk it and go to the hospital yourself. Because back then, if you were able to have someone drive you, that was the same, if not better, than calling an ambulance, because then you didn't have to wait for the ambulance to come, and the ambulance wasn't providing you care as it was. So being able to educate the public was a part of this standard that they laid out, and also having EMS participate in injury prevention programs. Those still go on today. One of the biggest ones that we do are car seat checks. People will come to the station and have you make sure that their car seat is installed properly, especially new parents. And that goes into injury prevention program. Another one is if you're checking blood pressures at the local senior center so that you can catch someone who routinely has high blood pressure. That's a form of injury prevention, and that falls under our public information education. Another thing that was laid out was medical direction. So every agency, whether it's a fire department or ambulance, has a medical director. That medical director is an actual doctor, and that doctor is responsible for every single provider in that department or agency. You technically, once you finish your EMT class and you test out, you are certified as an EMT. You're not licensed as an EMT. And as a certified EMT, you have to practice under a medical license. So your medical director has a medical license, and that's who you practice under. So if you do something, you're doing it under his license, which also means if for some reason you're called to court and being sued for negligent care, which we'll be talking about in Chapter 3, oftentimes whoever's suing you will probably sue the department, and they'll sue your medical director because you're practicing under his or her medical license. So the medical director is accountable for everyone in that agency. Another standard that they developed was trauma systems. So as I said before, Upstate is our trauma center. That came out of this standard that we have, is saying that certain hospitals have to have certain standards to be eligible for traumas. One of the ones is you have to have a trauma surgeon on call 24/7, and they have to be able to respond to the hospital or be at the hospital within a set amount of time. Usually it's minutes, or if it's depends on the level of traumatic injury. But upstate will always have a trauma surgeon either there or on call and able to get there very, very quickly. And then the last one, this one's huge, evaluation. So establishing programs for evaluating and improving effectiveness. You have, in parentheses here, QI, QA, and TQM. QI is quality improvement, QA is quality assurance, and TQM is total quality management. Another one in there that's pretty prevalent in this area is CQI, that's Committee of Quality Improvement. And their job is to it's to review people's performance. So when you do a call or you treat a patient, you have to document that care, and your CQI committee will review that documentation, and they'll review it throughout the entire agency, and they'll start to look for any trends that you might need to correct. So if they are reviewing a bunch of charts and seeing that all providers aren't doing one certain type of care, they'll say, oh, we need to educate our providers on this, and they'll coordinate with the training division and have a training put out so that we can further improve our care. It's also how you can identify providers that might need special attention. If you have one that might be providing care under the standard, that's how you can help identify and then be able to correct some of these issues. So being able to evaluate and have a committee that does that, so CQI committee, is huge. That is something that is tested on. I can tell you that right now that there are multiple questions asking about the purpose of evaluation, and the real purpose is to help improve our care overall. So EMS system starts with a 911 call. That 911 call goes to your dispatch center, and pretty much every dispatch center in the foreseeable area has trained emergency medical dispatchers. It's something that is still technically optional nationwide to do, but most of the people in this region have that done, and it gives our dispatchers a little bit of training to be able to recognize some medical emergencies and be able to help people with directions over the phone. So that's how some people have instructions on how to give CPR to someone who doesn't have a pulse. They'll be getting it from their emergency medical dispatcher. It's also twofold because with their training, they are able to recognize the category of emergency that we are going to be responding to. So they can identify if it's a chest pain patient, and they'll be able to go to a checklist. They have different cards, and so they'll have a chest pain checklist, both of directions to give the patient, but also directions of who to dispatch to it. So they might dispatch to chest pain, they'll dispatch an ALS unit, they might dispatch the fire department to go with it. In certain cases, they might dispatch a police officer because they need someone who's closer to respond immediately. So the EMS system starts with our dispatchers and then follows up with EMS responders, which are you guys. Whether you guys show up with the fire department first or you guys show up with an ambulance that's transporting. Then we bring the patient to the emergency department at the hospital. And the emergency department, they'll see doctors, nurses, and then they'll also have allied health personnel. That kind of encapsulates the rest of healthcare in general. From the emergency department, they'll receive what's called a disposition. A disposition can either be discharge home, discharge with instructions to follow up with someone, or it could be admission to the hospital for further care. Either way, if they aren't able to solve the problem in the emergency department right then you're usually referred to a specialist, whether it's while you're admitted to the hospital or a follow-up appointment. And so that's where the specialty centers come into play. It will be where you can have that specific complaint that you had stabilized during emergency, treated and managed by a specialist. So I know that we discussed trauma centers a little while ago. There are some other specialized care facilities. You have to be aware of these specialized facilities in the area that you work. So trauma center, as we said, was upstate. You also have burn centers. Usually burn centers and trauma centers are the same hospital because a lot of times burns and trauma go hand in hand. So in this region, the burn center is upstate. You also have pediatric centers. Pediatric centers are ones that have specific facilities to treat kids. Every hospital can treat kids to a certain extent, but some hospitals actually specialize in it and have all the capabilities to treat any type of illness or trauma that a child might face. In this area, the pediatric center is upstate. And then you have cardiac and stroke centers. These are ones that are capable of treating heart attacks or strokes, respectively. And they have specialized equipment. So like for cardiac, they have the ability to actually go into your heart's vascular system and retrieve a clot. Same with a stroke. They're able to actually take care of the clot inside of your brain. In this region, for cardiac centers, every hospital in Syracuse, except for community, is a cardiac center. And stroke centers, upstate and Crouse, are your major stroke centers. St. Joe's is in the process of becoming a stroke center, but in my opinion, they haven't quite caught up to the full capabilities that upstate and Crouse have had for a little while now. So we just discussed some of this. What medical services are available in your community? So knowing your hospitals and knowing the specialties that they do is huge, whether you work in the Syracuse area or you end up moving and you work in the Rochester, Buffalo, Binghamton area or out of state. One of the first things you need to know is what medical services are available in your community and where to get them, because we are the ones that are going to be informing our patients about it. Most people don't know where your nearest stroke center is or where your nearest burn center is. So if you have someone who has chest pain and you recognize that's a heart attack and they need a cardiac center, but you're 5 minutes away from their local hospital that they've gone to all their life, but they can't treat cardiac, you need to be able to calmly and effectively communicate to them why that's not the appropriate choice because they are not able to treat the specific thing going on that day. And a lot of people get very upset when you tell them that they can't go to the hospital that they want to go to because they don't understand that different hospitals have different capabilities. So that's something that we really have to specialize in and be able to effectively communicate to people. So here's just a little flow chart. This is in your textbook of accessing the EMS system, starting with the patient, person calling 911, to your emergency medical dispatcher, to emergency medical responders, to EMTs, to emergency department staff, to your allied health staff. So everything that we just talked about. So as we said, the 911 system was established back in the 70s. It's available in, I believe, every community nowadays. There might be a remote area somewhere in the country that does not have 911 telephone access. There's also what's called enhanced 911. That was all the rage about 20 years ago, that you were really advanced if you had enhanced 911. Enhanced 911 provided the caller number and location. If you called from a landline, provided it immediately to your dispatcher so that it just popped up on their screen. It's essentially caller ID with having a house number to pop up with it. So that's something that is standard everywhere. I've not heard of a 911 system that does not have that function nowadays. Like I said, it was huge 20 years ago when it was newer technology, but nowadays it's pretty much everywhere. So as we discussed, emergency medical dispatchers can provide instructions on caller or instructions to callers on how to provide a little bit of care until we get there. And it's required in some jurisdictions. I know in at least Oswego and Onondaga County, it's required. And I haven't heard of a county in this area that does not require it. So going on to your critical decision making. That's really one of the key parts of being an EMT, is being able to make critical decisions under pressure and make them fast and make good decisions. So in order to make a critical decision, you have to gather all the information possible You have to assess your patient well and make a good determination on your treatment and transport options. So knowing all the different options available to you and then be able to pick from those options. As it says, decisions are often time critical and can really make a difference on patient care. So a few examples of critical decisions here. One is it better to take patient to the closest hospital or to one further away but more appropriate for the condition? Which we already discussed. It's almost always better to take a patient to the appropriate facility even if it's further away. Another one that's made on many calls is evaluating whether the patient is stable enough for further evaluation on scene or if they should be transported immediately. And that comes down to recognizing what you can and can't do for the patient and long-term effects of it. If you have a massive trauma patient, we are not trauma surgeons. We can't cut them open and fix the problem. So we shouldn't be staying around and evaluating them for a long time on scene. We need to get them to a hospital where you have a trauma surgeon who is able to actually fix the problem before it kills the patient. So being able to make that determination of is the patient stable enough to treat them on scene, or if we really need to get them going to the hospital. That's done on almost every call, is making that determination. And then the basic, will this treatment make the patient better or worse? Even if something's in your protocols to do, we're trusting your judgment and your decision-making skills to be able to decipher if the treatment will make the patient better, or sometimes it can make them worse, and be able to withhold that treatment if it's going to be something that might harm the patient. So going into the levels of EMS training, we have 4 main levels of EMS training. They're listed here from the least amount of training to the most amount of training. So we start with the emergency medical responder. Were previously called first responders or certified first responders, shortened as CFR. So if you ever hear that term hanging around, and they're really trained to be the first few minutes of a event. They aren't trained to transport patients. They aren't trained to take refusals of care on patients. They aren't trained to do long-term care. Their training is mainly just immediately stabilize some big life-threatening issues. Then you move on to EMT basics, so your emergency medical technicians. That's what you guys are in class for right now. EMT basics, you're specializing in actual long-term care of the patient, so you get to transport the patient. You get to take care of them for minutes or sometimes hours on end and be able to actually continue care beyond the first few minutes of stabilization. Going on to level further, you have your advanced emergency medical technician. This used to be called your intermediate EMTs. Now they're just called AEMTs, which stands for advanced EMTs. Advanced EMTs are able to do IVs, some invasive airway maneuvers, and give a limited set of medications. Usually the first round of medications for critical patients they're able to give. And that's great for especially rural areas where it might take a while to get a paramedic to a patient, because then they can get things started and get the first few minutes done of advanced level care before the paramedic gets there. And then lastly, you have paramedic, which is your highest level of EMS training. Paramedics are able to do advanced cardiac monitoring. They're able to do a wide array of advanced airway maneuvers. They're able to do a bunch of different IV medications, and they really design or specialize in the full breadth of emergency care. Let's go into some roles and responsibilities of EMTs. First and foremost is personal safety. You're going to hear this repeated over and over and over again throughout this course. You need to make sure that the scene is safe and that you're safe. If you're not safe and you get harmed or hurt or something happens to you, you now not only can't take care of your patient, but you become a victim as well, to where resources need to be dedicated to treating you or helping you out. So making sure that your safety is safe is paramount. And going hand in hand with that is making sure that the rest of your crew, the patient, and bystanders are safe. Typically, if there's a threat on scene, it's not just towards you, it's going to be towards everyone on scene. If you are in the middle of a highway because there's a car accident there, You won't be safe if there's traffic flowing, and that traffic flowing doesn't just put you at danger, it puts everyone on the scene at danger, which is why we shut down roads to traffic when we have car accidents. So that's something that we have to think of first. Before we do anything, we need to make sure that us and our crew, patient, and bystanders are safe. Another role is patient assessment. Your ability to assess what's going on with a patient, that's what we mainly learn about in this class. It goes hand in hand with you providing care, because your assessment will tell you what type of care needs to be rendered. So having great assessment skills is huge to being a good EMT. So going on from assessment, having good patient care, so knowing your skills, knowing how to do different things to your patient, and being able to go from your assessment to patient care. Those are huge responsibilities of EMTs. Also, lifting and moving. We'll have an entire class dedicated to lifting and moving. That's something that I like to think us as EMS providers specialize in. It's something relatively unique to us because we don't have a controlled environment like most of healthcare. Most of healthcare, you have a patient in a hospital room, you have lots of space. The most moves that you really do is either assisting them walking or you move them from one bed to the other. We have a wide array of scenes that we go to, and we have a wide array of people we have to move in different spots. People in the hospital are not pulling their patients out of a car. They aren't carrying patients up a cliff. They aren't in the patient's house and have to carry them up 2 flights of stairs from the basement. So it's a lot different being out in the field where EMS practices than people in a controlled hospital environment. So we have to be really big experts on lifting and moving our patients. That's something that is kind of unique to EMS, is knowing all the different ways that we can lift and move our patients. That's why we're going to have an entire class dedicated to hands-on actually doing that stuff. Then moving on, the obvious one is transport of our patients. That's a huge role that we take, is transporting our patients to the hospital. And then our transfer of patient care. Transferring patient care is vital to us. That's where we transfer our patient to a nurse at the receiving hospital or to a paramedic who comes on scene, and you give your patient to them. Being able to effectively communicate with whoever you're giving your patient to is huge, and we're going to discuss it a little bit from now. But you need to not only be able to do your assessment and do your care, but you need to be able to effectively tell whoever you're giving your patient to the assessment and care that you did, because that might be what determines how they treat a patient. If you, for example, have a patient who has chest pain that you missed on your assessment because you weren't asking about it, and you get to the hospital and you say that they had toe pain instead, the nurse that you're giving report to and transferring care to won't pay attention to the patient for quite some time. They'll probably put them in the waiting room for several hours and they won't see someone. And so their chest pain is going to go untreated because you missed it on your assessment. And so when you transfer patient care, they missed it when they got their patient. So transferring patient care is huge. And then lastly, patient advocacy. You're going to hear this echo throughout the entire class to be a good patient advocate. And being a good patient advocate, it goes in many different facets of the job. It's making sure that you know what's best for your patient and that you're fighting for what's best for your patient. That could be as little as if you're at the hospital and the nurse wants you to put the patient in the waiting room, but you know that the patient has severe pain if they're sitting on if they'd be sitting in a wheelchair and they need to be laying flat on your stretcher. Patient advocacy is saying, no, we can't put them in a wheelchair. They need to stay in a bed, whether that be my stretcher, which means we have to stay here longer, or getting them a bed in the emergency room. And then we have a few other examples of being a patient advocate on the next slide. So if you think about it, how would it impact an older adult patient if they were transported to the hospital without their glasses, hearing aid, or dentures? Okay. So most of the time when we're called, seconds don't matter too much. We usually have a few minutes that we are able to gather things and make life a lot easier down the road. Yes, it doesn't really change what we do if they have their glasses, hearing aid, dentures, stuff like that with them. But if we don't bring them with us, we get to the hospital, then they're going to go hours without being able to see or hear or speak correctly, which is really puts the healthcare providers at a disadvantage and the patient at a disadvantage, and can be frustrating for everyone involved. And it's something that's easily fixed by us taking the 1 minute while we're on scene and making sure that they have everything that they need. Because a lot of times they aren't going to remember because they're focused on whatever emergency is going on. If you're having crushing chest pain and you can't breathe, that's not a time that you're thinking, oh, do I have my hearing aids or glasses with me? Because you're focused on that. So us, since we aren't experiencing the emergency, it's our job to be an advocate for them and try to think ahead to things that they might not be thinking about at that time. Another one is assuring that the home is secure and locked before leaving. It's something that takes time for us to find keys and to lock the door. It can be annoying for us as providers to take that extra step, but giving the patient the peace of mind, knowing that their home is secure, and making sure that while they're gone, no one breaks in, is part of being a patient advocate. And like I said, you're going to be hearing patient advocacy throughout the entire course. Another example that we can think about is, can patient advocacy extend to the community? So fall prevention programs or poisoning awareness or safety programs for pool and water. And one of the biggest ways of being a patient advocate is if you're in an elderly home, see some of the stuff that you might be able to prevent an injury from occurring later. Like if you have a rug that is kicked up, that could be a trip hazard for an elderly patient. So fixing that, or if you have a hoarding house where it's not easy to move around in, try to at least talk with the patient, if not help them move some things so that you have a good exit in and out of the house for in the event that there might be a fire or something like that. One of my biggest ones, since I'm also a firefighter, is if I go into a house and there's the smoke detector chirping a low battery alarm, that's when I'm going to just remind the patients, hey, this chirp means you don't have a good battery in your smoke detector. It's probably not working. You would be surprised how many people don't know that that means that the battery is low and that their smoke detector probably is not functional. So that alone can hopefully save a life or two if their house ever catches fire and you have functional smoke detectors. And that all is part of patient advocacy. All right, so some physical traits of good EMT. Your ability to lift and carry equipment in patients up to 125 pounds. You can be the best book smart EMT out there. You can know everything there is to know about emergency medicine. But if you can't, one, carry your equipment to the patient to treat them, or you can't carry the patient yourself, then you aren't going to be much good. There's circumstances where, yes, we need to call for other people to help move our patients. There are patients that are extraordinarily heavy, but being able to lift 125 pounds each person, so you and your partner are able to lift that amount, that will cover most of our patients and all of our equipment that we need to be able to carry. So being able to be in good physical shape and being able to lift that amount is huge to being a good and successful EMT. And like I said, we will have a whole day dedicated to lifting and moving and teaching you guys the right techniques. You'd be surprised how much weight you can lift easily when you actually use the right techniques. Another thing that you need to have is good eyesight. One of the best examples I can say for that is if you have a patient who overdosed on medications and you need to know what those medications are, you need to be able to actually read that small fine print on the bottles to find out what the patient overdosed on. So being able to read is huge. And then be aware of any problems with your color vision. It's not a disqualifying factor, but be aware of it because some of our assessment is looking at color. If your patient has blue skin, that's a sign that they aren't breathing well. And if you have issues with your color vision, you might not be able to see that. So being able to recognize other signs and symptoms if you're able to see color well, is something that we're going to be having to teach you. And then also having your good communication skills, both oral and written. This goes back to a lot of transfer patient care issues. You need to be able to effectively communicate what you did to the patient, both in real time when you're talking to someone, and then afterwards when you document the call. Because your documentation, not only is your CQI committee for quality assurance is going to look at it, but also that goes into the patient's medical record. Doctors will reference that documentation that you write and find out what you did to the patient. There's the old adage that if it wasn't documented, then you didn't do it, because we leave pretty quickly from the hospital, so they have to rely on our documentation to know what was and wasn't done. So if you gave aspirin to a chest pain patient and you didn't document it, they're going to look at your documentation and say, oh, there's no record of aspirin being given, we need to give aspirin. And suddenly the patient now has double the dose that they should have gotten. So you need to make sure that your communication skills, both oral and written, are right up and being top notch. And we do have a whole day dedicated to communication and documentation. Some personal traits of a good EMT: he should be pleasant, sincere, cooperative, and resourceful. Resourceful is my favorite one to talk about because, again, we do not have a controlled environment. We have a finite amount of resources that we sometimes can't always access because we're might be in a patient's house. A hospital usually has a plethora of supplies and personnel, endless supply of ability to do things. Sometimes we have to be very creative because of the position that we're in, especially if we're on scene, or if we don't have enough supplies to do something. So we have to be very resourceful and being able to adapt to our environment very well. Really, when you're thinking about personal traits in EMT, just think about what you want to see from someone who's treating you. If you have a doctor treating you or a paramedic who comes to treat you, you do want them to be pleasant and sincere with you and cooperative with you. You don't want someone blowing off the handle and being uncooperative with your requests. Another big part that you'll see me drive into you is having a good professional appearance. A good professional appearance inspires confidence in your patients and in your other healthcare staff. If you show up and you have basketball shorts on and a t-shirt on and you look like you just ran 5 miles, that doesn't usually instill much confidence in the patient. Now, I get it. I really do. If you are at home and you're on call with the fire department, you're mowing your lawn, and then a call comes out and you go assist, that's one thing. But if you're going in to be on shift at an ambulance company and you know you're going to be there, please dress professionally. Be well groomed. If you're shaven or if you have facial hair, have it at least kept well. Don't be really rugged. Have you a nice polo or button-down shirt, whatever uniform is. Tuck it in. Have long pants. Have nice boots on. That goes a long way in getting confidence from your patient and respect from other healthcare providers. If you don't look like you know what you're doing, you don't look professional, a lot of the healthcare providers that we work with, whether we're taking a patient from a doctor's office or we are giving a patient to the hospital, they aren't going to take you seriously if you don't look serious. So other personal traits of a good EMT: have to be a self-starter. A lot of times it is just you out there. There's no supervision. The week after you get your EMT card, you might be on a call with 4 other firefighters who don't know anything because they aren't EMTs, and you're the only one there. So you have to be able to be a self-starter because no one's going to be poking you saying, hey, you need to do this to the patient. Also, being emotionally stable. And that's because a lot of our patients are not emotionally stable for one reason or the other. Usually it's because they're facing some sort of emergency at the time. And so we need to be able to calmly and rationally deal with them. And that's really hard to do if you're not emotionally stable. We're going to talk about that in depth in Chapter 2, which is the well-being of the EMT. You need to be able to lead because, like I said, if you have a bunch of firefighters who aren't EMTs, it doesn't matter if they are your fire chief. You have to lead them because in a medical situation, it doesn't matter what standing they have in the fire department. The highest certified medical provider is in charge. So you need to be able to be a good leader. Being neat and clean, that goes right in with your professional appearance. And then be of good moral character and respectful of others. That should be obvious, but we do have to say that. You need to be a person of integrity. You also need to be in control of your personal habits. If you can't go 10 minutes without smoking a cigarette, that can be a problem because you can't smoke while you're on a call, and calls can last several hours. So be in control of your personal habits. If you are an alcoholic, you need to get that under control because you can't show up to a shift or a call while you're intoxicated. You need to be controlled in conversation and able to communicate properly, which we discussed with being able to talk to other healthcare providers and being able to talk to your patients. And you have to be able to listen to others. That's a huge thing that doctors have an issue with, is they only pay attention to the first 10 to 15 seconds of what their patient's saying, and a lot of times they will kind of zone out, which will lead into medical errors, and that's a huge frustration in the medical community, is patients feeling like they aren't being heard by the people who are taking care of them. This also comes into play when you're getting a report from someone, whether it be a nurse or doctor at an office or another EMT when you show up as a transporting ambulance. You need to be able to listen to what they're saying so that you know what assessment they did and what treatments they did. And also, you have to be non-judgmental and fair. This seems obvious, but there are some times in your career that you are going to be treating patients that you have prejudice to. I spent a lot of my career working AMR in the city of Syracuse. They have the Justice Center in the city of Syracuse, and so I'd be called for a lot of inmates who are in the Justice Center for doing some pretty heinous things. There are some people that were child abusers. I personally don't like child abusers. I don't think anyone really does. But I need to be able to treat that patient without judgment and fairly, and treat them as well as I would treat any other patient, because that is our job as an EMT, is to deliver high quality care to everyone regardless of the circumstances. So one of our big roles is to continue our education. So you're in class right now, you're getting your initial education. I can tell you right now, I cannot teach you everything there is to know about being an EMT. It's just, there's not enough time, and frankly, being a paramedic, I don't know everything there is to know about EMS. I've been doing this for 10 years. So once you're done with class, understand that your learning and knowledge does not end with class. You need to be able to keep on taking classes and courses and keep your education up. And that's twofold, because you'll learn new things, but you'll also maintain some skills that you don't always use. There's some skills, say inserting an oral pharyngeal airway. We're going to teach you that in section 2. And it's a relatively simple procedure and it's life-saving. But if you don't do it for 4 years, you might forget how to actually do it safely. So being able to maintain your education and get hands-on for some of the equipment that we use so that you don't forget it. That is really, really big, and New York State agrees with that. That's why you have to fully recertify your EMT card every 3 years. They understand that we do forget a lot of things that you learn in class, which is why you need to recertify. And there's several different ways to do that. We'll talk about that later. So New York State thinks that education is huge too. As a paramedic, I have to complete 12 hours of continuing medical education every 6 months in order to continue practicing as a paramedic. EMTs have a little bit lesser rules, but it just goes to show how big of an emphasis they really put on education and continuing our education. So just take a second and think about how will you refresh your knowledge and stay current once you're out of the classroom. There's several different options. There's classes, seminars, there's training weekends, there's training nights. There's a wide array of things that you can do to continue your education. Also think about, what qualities would you like to see in the EMT who's caring for you? And that's really, if you think about that, that will hopefully show you all the traits that you need in yourself. Now think of how you would want to be treated if you were in the patient's position. That will guide you for a lot of how you should act as an EMT. Also, think about where will you become a provider. There is a plethora of options out there nowadays. You have the obvious ambulance service. That's the bread and butter of EMS. You also have fire departments and first response departments. But there's also a wide array of things like rural or wilderness teams. You can volunteer somewhere. You can every day there's more roles for EMTs. I just saw a posting the other day about an EMT needed full time to do cross country skiing events and just be standby on those. There's children's camps that need EMTs. School nurses for the substitute for the school nurse, an EMT can do that. So every single day, it's expanding more and more of what an EMT can do. So you can become a provider in a wide array of settings. You can even there's options to be a EMT on a cruise ship and work the medical team on a cruise ship. So it's just if you name it, there's probably a way an EMT can get involved. So I know that we mentioned this near the start of the lecture, the founding of the National Registry of Emergency Medical Technicians. So the National Registry was established to kind of give national standards and allow for transition of people from state to state a lot easier. As I said before, you get certified by New York State. New York State is actually one of the very few states left that does not actively recognize the National Registry of EMTs, but they are very quickly moving towards that, probably within the next year or so. That's when that will take effect, where they recognize National Registry. And so if you get a National Registry certification, which is a separate certification, it allows you to move from state to state to state to state flawlessly. So a Virginia EMT who's on the National Registry can go to Arizona and begin to practice pretty immediately without having to seek what's called reciprocity, which is having contact the state Department of Health and go through a bunch of hoops of how to become an EMT in that state, given that they had a Virginia certification. So it's also sometimes beneficial when you're applying for employment. Employers sometimes look at that as a additional perk to having you as an employee. So it's just another thing to think about, and it will probably be mandatory coming up in the next few years in New York State. Again, touching on CQI, so quality assurance or quality improvement, it's the continuous self-review with the purpose of identifying aspects of the system that require improvement. You also develop plans to correct deficiencies and improve performance. Now, 15 years ago, CQI was much more punitive than it is now. If you were contacted by your agency's CQI committee, usually that was not a great thing. The joke was when you show up to the meeting, make sure you bring your EMT card with you so they can shred it. That's a thing of the past. Now, CQI nowadays is very focused on training and improving our providers. So we aren't trying to punish providers. We're trying to make things better for both our providers and our patients. So in CQI, so everyone in your organization has a role in CQI, whether that's you who is writing the chart and making sure everything's documented right, or if you're actually becoming involved in the CQI committee. Where I'm a full-time employee, I'm on the CQI committee, so I'm one of the ones that actually goes in and reads charts that are written by other people. I make sure that everything that needs to be documented was documented, and also I made sure that the care was appropriate so that we're giving the highest level of care possible to patients. Also, part of CQI is getting feedback from patients themselves and hospital staff. Sometimes it's a follow-up to see how the patient did and if our care had an effect on the patient. And CQI can help maintain your equipment if we're finding that our equipment's hard to use and we're not giving good care because the particular model we have is not an easy model to use. We can change that equipment out, or if it's broken, we can change it out. And then also continuing your education. Again, finding any weak spots that providers or everyone in an agency might have and forming a way to educate people on how to be a little bit better. It's all part of CQI. Touching back on the medical direction, so as I said, every agency has a medical director, and all of your patient care is done through that medical director. In fact, paramedic, if you break the word down into the Latin words, medic means doctor, and para means through. So paramedic literally translated is through the doctor. So we're giving care through the doctor. We're an extension of him and an extension of their medical license. Or her, sorry. My medical director is a him. So as such, your medical director ultimately is responsible for the patient care, and they oversee everything. They oversee your training, your treatment protocols, and they can provide what's called medical direction. So medical direction, this is a key point. This will be tested on. You have two different types of medical direction. You have online medical direction. That is when you speak directly to the doctor. So whether it can be usually a phone call or you're talking to them on a radio, and you are in real time talking to the doctor about the patient, and they can give you real-time orders back. So if there's a patient that I want to give a specific medication to, I can call my medical director or the receiving hospital and talk to a doctor there and say, this is my patient, this is what I'm seeing, this is the drug I want to give, can I give it? And they can come back and say, yes, go ahead and give that drug. And that is providing online real-time medical direction. Now, if we had to do that for every single patient, that would chew up a doctor's time 24/7. So we have what are called offline medical directions, and those are what we refer to as standing orders or protocol. So those are all three of those terms you need to know: protocols, standing orders, and offline medical direction. And what that is it's usually written out. We have protocol books saying, if you see this type of patient, these are the drugs and procedures that you can do to that patient. So if you have a chest pain patient, you, as EMTs, have standing orders to give them aspirin and a specific dose of aspirin, which we'll cover in our cardiology lecture. So every single patient you are allowed to give that to. They expect you to know when you can't give it. There's things that's called a contraindication, which says when you can't give it to a specific patient. But your offline medical direction or standing orders say, we trust your judgment to give this medication when it's appropriate. So that governs most of our care. We have standing orders for most of our patients, but sometimes there's a high-risk medication or another high-risk thing that we really want a second opinion on, and that's what online medical direction is for. So if you have a chest pain patient, there's another drug called nitroglycerin that you as EMTs can't give standing order, but if you find a patient that you think really needs it, you can call medical direction and ask for an order to give the nitroglycerin. So EMS role in public health. You have the injury prevention for geriatric patients. You can see there's a picture in the bottom of the rug that's loose and someone's fixing it, just like I mentioned earlier in the class. You also have injury prevention for youth, making sure that youth know to use their bicycle helmets when they're on their bicycle. Also, public vaccination programs. That's sometimes something we can help participate in. You can be trained in giving public vaccinations, like when the COVID-19 vaccination came out. Some areas tapped on their EMS providers to administer that vaccination. And then disease surveillance. Oftentimes we're on the front lines of seeing diseases because we're actually out in the community seeing these patients. So a perfect example was COVID. I was asked all the time by people, oh, how bad is COVID right now? How bad is COVID right now? And I actually had a pretty good grasp on how bad it was in my area because I could go and see how many people I was transporting for COVID. So we do have a unique view for public disease surveillance. So really the main takeaway from research, and this part, I do apologize, this part might get a test question or two, but the main takeaway is to be able to improve our patient outcomes through evidence-based techniques. So we use research to improve our care. So research kind of like CQI is what we can use to say, well, this treatment's working and this treatment's not working. So we're going to change how we treat our patients to the one that is working. So of everything to remember, just remember that research drives our evidence-based practice. So in order to do research and come up with a conclusion, we follow the scientific method. So you have to form a hypothesis, you review the literature, you evaluate the evidence, and then you adopt the practice if evidence supports it. So remember that the EMS system has been developed to provide pre-hospital care as well as hospital emergency care. The EMS system includes 911, that includes dispatchers, then EMTs, hospital emergency departments, physicians, nurses, physician's assistants, and other health professionals. The EMT's responsibilities include safety, patient assessment and care, lifting, moving, transporting patients, transfer of care, and patient advocacy. Again, you're going to hear that word over and over in this class. An EMT must have certain personal and physical traits to ensure the ability to do the job. Feel free to go back and look to see what those traits are. Then education, including your initial training and refresher training and general continuing education. Quality improvement procedures and medical direction are all essential to maintaining high standards of EMS care. I know that those areas will have questions that are tested on, so make sure that you know all the important areas of education, quality improvement, and medical direction. Keep in mind that EMS dates back to Napoleonic times, and the first EMS system we attribute to the French back in the wars back then. Modern EMS standards come from the 1960s and 70s and the National Emergency Medical Service Systems Act. And do remember that the white paper is what started all that back in the 1960s. That's what laid the groundwork for EMS to evolve. There is a chain of human resources involved in EMS, and critical decisions are made by each member of the chain. Keep in mind that there are certain personal and physical traits that will help you become a successful EMS provider. We listed all those in this class. And an EMS provider should actively pursue opportunities to improve personal knowledge as well as and abilities as well as the unit's overall quality. So some questions we want you to think about. What innovation was introduced in the Korean and Vietnam Wars that's now common in many EMS systems? That would be the helicopters that were used in the MASH units. We now see that in a lot of EMS systems, being able to fly patients that need more rapid transport. What are the 4 levels of EMS providers? So that would be the emergency medical responder, EMT, advanced EMT, and paramedic. And that's in the order of their level of training. Requesting orders from a physician by radio is an example of what kind of medical control? That would be online medical control. That's where you're speaking to a person real time and getting orders real time on how to treat a specific patient, versus your offline, which is your standing orders. So knowing your difference between online and offline is critical to know. Your patient is hesitant to go to the hospital because she is worried about her dog. What can you do to assist in this situation? What part of your role as an EMT is this an example of? So this is an example of being a patient advocate. And some things that we can do in this situation, this is a very realistic situation. It happens quite a bit, especially with elderly people that are very attached to taking care of their animals. So some things that you can do is possibly arrange for a family member to agree to come and stay with the animal. If the family member is not in the area, you can try to have a neighbor agree to come take care of the animal. You have to explain to the patient why it's important that they go get checked out, because they don't realize that if they don't get checked out for their chest pain, then they might not be there for the animal for the rest of time, because they might die if they don't get checked out. So being able to communicate effectively with your patient and get other options arranged so that we can get the patient the care that they need is an example of patient advocacy. It's one of the most common types of times that we can be a patient advocate. So that brings us to the end of chapter 1. Like I said, it was a little dry, but these are some important building blocks that we need to establish so that we can further go on through this course and talk about all the things about the body that matter in our job on our hands-on day-to-day life.